Okay. I do see our numbers have kind of settled down. I lied. There's another person. We'll give it 2 more minutes. Okay. Well, thank you all for joining us today. We want to welcome you to the HRSN HCBS grant overview. We're hoping to be able to provide some technical assistance today and give you some refresher updates and have some conversations. So I am going to move us forward in the slide deck. If you notice that we did start the recording so that we'll be able to send this out to individuals who weren't able to attend today. So I will do introductions first. My name is Bonnie Barron, she, her pronouns. I am the Medicaid Home and Community-Based Services Enhancement Analyst here at OHA. And I'm going to ask my 3 other presenters to introduce themselves, and then I will ask our subject matter experts in the room to add their names to the chat. And we'll go over who's in the room here on the next slide, but I will pass it to Cassie.
Good afternoon, folks. Thanks for joining. My name's Cassie LeVue. I use she, her pronouns, and I am the Medicaid Home and Community-Based Services Policy Manager here at the Oregon Health Authority. And I'll pass it over to Liz.
Good afternoon, everyone. My name is Liz Cancel, pronounced she, her, ella. I'm the Home and Community-Based Services Senior Policy Analyst, and I'm going to pass to Sharice.
Hello, everyone. I am Charissa Young-White. My pronouns are she, her, hers, and I am a case management analyst with the Oregon Health Authority, specific to the health-related social needs program.
Great, thank you. So those are our presenters today, but like I said, we do have quite a group of subject matter experts in the room today that may not be speaking, but will be monitoring the chat and will be working to answer questions and provide support as we go through the session today. So go ahead and just take a look at the list. I won't read them all off, but these are going to be your point people for safety net clinics, but also for the HCBS program and the HRSN housing support services. And then our partner entities, we have some contacts later on for Comagine Health and IN and Essentra. So we will also be providing a slide deck after the session in a PDF format via email so that you all have access to those contacts and these embedded hyperlinks that you'll see throughout the deck. I will move us forward. First, I want to familiarize some folks with Zoom. If you're not familiar with Zoom, there are some helpful features that can help individuals kind of share their thoughts. So we do want to invite folks to put questions in the chat, raise your hand throughout the session. I think because we have a smaller group today, we'll be able to honor questions throughout the slide deck if it comes up during a slide. We do ask that folks remain muted so that we can hear other individuals speaking, and we encourage everyone to turn off notifications or other distractions just to be to minimize interruptions and be a part of the conversation today. Any questions that we aren't able to answer in full in the moment, we will be taking back and be able to get back with you and ask for contact information to outreach and provide that support that you asked for. At the bottom of your screen, sometimes people will have it at the top of their screen, is a features bar that shows you how to mute and unmute. And then also the reactions, which is a little heart emoji. That is where your hand is hidden to raise your hand to speak. And then also the chat feature where you can click on that to start typing. And then sometimes if your screen is minimized, that chat feature might be in your 3 dots. So if you see the more section, it's a circle with 3 dots. There is not only sometimes the chat feature will be in there if you're on a different device, but also the Q&A feature. So that's a specific question and answer section where we can answer live questions directly to that individual, but we also can use the chat and respond in those places as well. And then go one more step here. For the Q&A, you would just click on that Q&A, which is in that 3 dots more button. And then a window will pop up and you can type your question, and then you have to click send in order for it to send. And then you would be able to see any responses that came from that. Okay. Great. I will move us to our agenda. So today we plan on going through welcomes and introduction. And then we're going to do an overview for 1959 HCBS program. Also the HRSN Housing Support Services. Then we'll probably take a little bit of a break, about 5 minutes. And we will then go through the grant purpose and activities, and also the reporting requirements, and then provide you some connection points and contact information for questions following this. And then we'll have open discussion and answer. Like I said, we likely with a smaller group are able to honor questions throughout the session, but also if you have them throughout and you don't feel comfortable coming off mute, you can definitely put them in the chat, and or we'll have some space reserved at the end for live question and answers as well. So I am going to pass it over to our first presenter, Liz Cancel, who will be providing us an overview of the home and community-based services.
Thank you, Bonnie. I was just typing that previously the slide didn't forward, happened in other presentations as well. So thank you so much. I'm going very, very quick over the 1915I services. You also have access to the full trainings. I'm going to share the link at the end of my short presentation. So home and community-based services are services and supports delivered to individuals in their home and community. The 1915I state plan option targets services for individuals with a chronic mental illness or severe and persistent mental illness. These services are designed to provide support to individuals with their activities of daily living, such as eating, bathing, dressing, or grooming. The goal of home and community-based services is for people to remain in the most appropriate setting, which could include their homes, community, or in 24 hours residential settings. 1915I permits states to offer home and community-based services to Medicaid eligible individuals who meet state-defined minimum needs-based criteria that are less strict than institutional criteria and state optional targets group criteria. May also provide services to individuals whose needs exceeds the state minimum needs-based criteria, including those who meet an institutional level of care. Could you please move forward, please? CCO enrolled members and fee-for-service open card members can apply for and be eligible for 1915I services. The eligibility criteria include to be enrolled in in Medicaid, be 21 years of older of age, not require facility-based care, need for one or more services at least every 30 days, and needs help with at least 2 activities of daily living or instrumental activities or daily living because of their mental health needs. Please move forward. Depending on eligibility, the individual may be able to access multiple services across various waivers or state plan options, as long as these options are not duplicative of each other. So this means that an individual can be determined eligible for more than one benefit. Active services under the approved waiver include community-based integrated support, psychosocial rehabilitation for persons with chronic mental illness, residential rehabilitation, and in-home personal care. We also have approved services that are coming soon. These services are not yet available, but we are beginning to develop them and more information will come soon. Those are community transportation, transition services, home delivery meals, housing support services, and pest eradication services. So now we are going to go over our independent and qualified agent that OHA contract with to ensure services and delivery to individuals, that individuals are connected and supported. That service is provided by Comagin Health since 2020. Comagin Health has been the independent and qualified agent for Oregon Home and Community-Based Services 1959 program for the eligible recipients. Comagin's ensure services and support are delivered and in appropriate way by performing functional needs assessments, making sure people have options to choose from among available settings and services, connecting individuals with resources in their community, developing personal center plan with active involvement of the individuals, completing medical appropriateness reviews and prioritization for services, managing transitions among settings, and providing a coordinated care approach to make sure individuals are receiving the service, support, and transitions they need to maintain and improve their overall health and best meet their needs and choice. Below, you see the ways that you can connect with Comagin Health. You can use the referral form, that is the CH006, Home and Community-Based Services referral form, the Comagin Health email, and also they have an electronic way to send messages. The 3 links are here, and you are going to have access to them when the presentation is shared. Finally, I want to talk about the referral process. This is a very condensed version. If you want to access the full training and webinar on this topic, I'm going to share the link here now. Okay. But first, individuals or providers such as community mental health providers or exceptional needs care coordinators need to confirm if 1959 services are applicable for the individual. Then financial eligibility needs to happen. A community partner organization may provide guidance on how to apply for Medicaid if the individual does not have benefit yet. Individual can apply with an outreach and enrollment worker in their community or directly on the one system. Additionally, information is available on the one webpage or by calling the OHP number. Then the 1959 eligibility determination happened. If individual is Medicaid eligible, this is step 3. And their mental health condition is the main driver of their need, the IQA conducts first the functional needs assessment, and second the level of care utilization system assessment to determine the needs of level of care and support that individual needs. Once the assessment are complete, a personal center service plan is developed together with the individual, their care team, and other preferred person for that individual. I want to highlight that the individual must have the mental health assessment and at least 2 activities of daily living. Needs and the needs need to be because of serious and persistent mental illness or chronic mental illness, and the treatment plan need to be completed to be approved for services. And then the 4th step is the service delivery. The IQA case manager work with the individual to offer choice of preferred providers and services. And then that could be the choice provider, certified mental health provider, and coordinated care organization to offer options to providers and services. Then the services begin and it's monitored by the IQA. And again, for a full training on this topic, please see the webpage that I just sent on the chat. If you have any question, I will be happy to answer those.
Feel free to raise your hand or come off mute if you have any questions for Liz.
Gosh, I got nervous. My tongue twist completely.
You did great. You did great. Before we move on, I do want to invite those in the room that are not OHA staff, I apologize, to put your name and affiliation in the chat or the clinic that you're affiliated with. That way we can kind of see who got to come and be able to provide this out to everybody afterwards. Thank you, Liz. I don't see any hands up right now. Doesn't mean there won't be questions later, but I am going to pass it over to Charissa.
Thank you.
Hey everyone, welcome again, but I guess I introduced myself earlier. Let's just jump into the next slide. So we're going to talk about the housing related supports, but specifically we're talking about rent and utility financial assistance today. So just as a note, housing related supports also includes home changes for health and safety to the home. So things like wheelchair ramps, air conditioners, grab bars, or new blinds for allergies. Things like that are also covered. But today we're just looking at rent and utility financial assistance. So that housing funding support for members. You've probably seen some of this before, but we wanted to make sure and provide an overview here. This is a very high-level overview. The member or the person requesting services on behalf of the member usually provides this information ahead of time to the to Accentra, rather, or coordinated care organizations if they're not open card, but we're really talking about open card today. I realize I'm talking a little fast, so I'm going to slow down a little. Like Liz, I think I got a little nervous for some reason today. So Accentra will review the request and they do the screening for the members and check for things like the qualifying health condition on here. But knowing who you're serving and how to support them getting these services, it's really good for you to understand their requirements, of course. So this benefit is intended to support preventing homelessness. So keeping people stably housed in their home. So this benefit is for people that are currently housed and renting. They would be at risk of homelessness. So I want to define what that means. Being at risk of homelessness in this particular definition, there's various ones, means that the household income is 30% or lower of the area median income for that region. So for instance, if you are in the Albany area, like I am, then and I have a one-person household, my income would have to be 17,500 or lower. So I just wanted to give that example. So you see, this is this is actually extremely low income limits. And this is according to the Department of Housing and Urban Development, or HUD. That's where we get our market rates. And that's where we set the line, is based on the HUD data. Another piece here is, while their income is very low, there also needs to be reasons that they need their rent and utility financial assistance, such as they don't have any resources, they're unable to pay their rent. This would be something like they don't have a big investment that they could pull money out, of a few $100,000. I mean, who has that? But we just want to make sure that we're getting to the people that really need it the most, so they lack the resources to continue staying stably housed. I already talked about a little bit about the qualifying health condition. This one's a little bit of a sticky, it's more difficult. It's really complex physical or behavioral health needs, things like recently being incarcerated and coming out of incarceration with some crisis experiences, for instance, so repeated use of emergency department use in crisis situations. Other things would include developmental disabilities and struggles with activities of daily living. Things like that. So those are on that housing eligibility fact sheet that we have linked on the bottom, and we won't go into depth there. So that's the overview. I want to pause because we want to make sure we have a good foundational understanding before we go on and see if there are any questions. And also, I'm really happy to, anytime while I'm talking, if you raise your hand or interrupt me or put in the chat, I'm happy to answer questions. But I will pause just for a moment here. Okay, great. It was good for me to take a breath as well. Let's go to the next slide, Bonnie. Thank you. Okay, so fee for service, FFS, is open card, that we're moving a little bit towards the open card language, but the fee for service language is still highly used in the provider community. So we wanted to keep using it. But you'll see here, who are you working with? You're working, of course, with the member that's part of the Oregon Health Plan on fee for service or open card, and Accentra, who does the authorization and then the care coordination for the member. So that would be, Accentra would be who you would be working with directly as you request services on behalf of the member or with the member. Probably would be, excuse me, the organization that you want to reach out to if you're wondering the status of a request for rental and utility assistance, for instance. And then, of course, providers. We have HRSN service providers. I think all of you, or at least most of you on this call, are probably enrolled. Many of you may provide direct housing services, so you could be cutting checks for rent and utilities, or you can be providing tenancy sustaining services and helping people stay stably housed. Those are also extremely important pieces of the housing benefit. And IAN is the third one. IAN is a contractor with the Oregon Health Authority, and they manage what I like to think is the back-end technical piece of this benefit, and that is claims verification and working with the Medicaid Management Information System, or MMIS. Okay, next slide, please. Thank you. So, of course, we could go into major detail on each of these pieces, but we're trying to keep this a little high level, and then I'd love to answer questions, like I said. And I forgot to mention that my colleague Tara Gray is actually our housing lead and will be able to answer detailed questions for you, whereas I may not be able to. So again, putting them in the chat or asking me is great. So the 5 main steps for members and HRSN service providers to be aware of is eligible members. You could outreach to your members, so you can actually call up members and say, hey, based on our records, I think you might be eligible. Are you struggling with this? Let's take a look at that. You know the people in your clinics the best. People could reach out to you. Members could come to you and say, hey, I need help. I think I might be eligible, or I heard something about this. So that's the piece of identifying members and reaching out. The next step is where if the member requests housing, rental, utility assistance, and other HRSN benefits, this is where Accentra reviews the request, and then they look in depth at the member's conditions, what the member submitted, and they determine based on criteria that we've set in rule and guidance if the member is eligible. So if they have this complex behavioral health condition, for instance. The next step would then be authorizing the service. So Accentra authorizes the service for the HRSN eligible member, and then would communicate with you as an HRSN service provider. This was authorized, or send a referral to you. We authorize this person. Can you pay the rent? Can you provide them with tenancy services? It could be that you're not cutting the check necessarily for rent and utility payments, but you might be doing other work supporting the member staying stably housed. So there's this two-directional piece. You're talking to Accentra, and Accentra is talking to you. That is the hope. We want to increase that communication there. I kind of jumped into this already because it feels like a similar step. So there's authorization on Accentra's side, but then there's that referral and then delivery of housing services, which is all in the same time period there. And then, of course, it's extremely important that y'all get paid for doing the work that you're doing for Oregon Health Plan members. So let's go to the next slide here. Accentra and Ion, all of our contractors and our coordinated care organizations, if you work with them, they do they use the rates in our fee schedules here. And I'm going to open up and I will paste the links in as well because we have 2 fee schedules. Well, actually, there's 4 posted on there right now, but there's 2 that you're really interested in. So Bonnie, I think you're going to open up the first one for us here. That would be great. Thank you. And I'm going to pop it in the chat. So this is the fee schedule effective when the housing benefit went live. Thank you so much. You pulled it over wonderfully. And it's long. It just feels a little bit, it could feel a little overwhelming for some folks. I know you're all, you have clinics, so you're probably used to billing, I think, and I hope. But essentially, let's go down a little bit. This is our home changes for health, which I touched on, but let's go to the rental and utility assistance page. And that would be, yep, just one more here. Oh, I'm sorry, go up a little. My bad. My eyes aren't working clearly. This is the page here. So from November 1st to October 31st of this year, so here in the next month and a week, these are the rates. So this is the supported housing, rent and utility costs, and what the rates are based on region. And so it is a little complicated. If you click on the region, it will tell you where that is. So region A, I believe, is the metro area, for example. I don't have them all memorized. And so you'll see here, there is utility costs. Those are the upper payment limits there based on bedroom size, 0 to 1, 2, or 3. That's for utilities. And then the next one is rental costs, and that has the upper payment limit for the next one would be the very bottom line, H0044 there. So that is the upper payment limit. So the most you can get paid for that, except there is a caveat. These expected costs are actual cost. You can't go over this, but you don't bill for the full amount. You bill for what that person's rental needs are. Let's see. Casey, is there consideration to leverage existing billing clearinghouses for electronic billing and payments to streamline processes providers and for OHA and the Medicaid Management Information System? That's a really good question, and I'm going to have to take that one back to the to OHA and probably a different team. I don't have the expertise on the clearinghouses here. Unless, Tara, you have any answers on that.
I do not on that one. We'll have to bring that back.
We'll come back to that for sure. Thanks, Casey. Okay, so let's scroll down a little bit here. We're not going to go in depth on all of this. You'll see on the next page, there's 2 and 3 bedrooms, of course. There's more utility information for arrears and setup. And I want to keep going down. Actually, let's go back to the slide. I'm sorry, I forgot I put the picture on the slide. That would be easier to look at. Okay, so this is what's really important. We won't open up the November 1st rates. You'll see the differences there. The document looks the same and reading it is the same. So, but what's really exciting is that there are increased rates for outreach and engagement and tenancy services. So that means if you are a housing provider, or if you're also enrolled as an outreach and engagement service provider, you can bill for the time spent connecting people to resources or helping understand their lease, potentially skill building, anything that leads to stable housing under tenancy services. Outreach engagement is even more open. It's really anything that connects members to resources that they need based on their social or healthcare needs. So legal aid, education, Social Security and applying for that, or understanding the bill, or not the bill, but the payments, things like that would be covered under this. And so the rate is going up effective November 1st to $26 per unit, which equals to $102 per hour versus the previous $80 per hour. And that was for hopefully to help sustain our services, the HRSN program for providers. So that's exciting. I'll pause here. Any questions on this that I can answer? Sorry, the one question I was asked I couldn't answer. Okay, great. So next slide, please. I'm about done talking, but this is really important. We want to bring this out here. If you have not attended an HRSN office hour, this is a really great place to bring questions. You can pre-submit questions and we provide written answers. And then we go through ones that are either really complex or that we heard a lot from a lot of folks. So we answer those questions, and then you can also ask questions in real time and hopefully get answers. I think for the most part, we answer about 90% of the questions at that time. Some we have to take back, like me today, we do that. But it's just a really great hour. It's actually, and I didn't fix this, I apologize, but it's going to be an hour and a half in the future as well, because we've had such overwhelming response to the HRSN service hours that they're helpful. Our transformation center also runs this. It's usually always that I've seen presented in a really clear and concise way, and it seems to be really helpful. So those are the upcoming trainings for enrolled service providers. And you can click on the links here. I will go ahead and put the HRSN program email in the chat as well, because I think that piece is also really important. That is a dedicated email for the intention is for our HRSN service providers. Members and anybody else could use that email. We won't decline anyone or ignore it, but it's really for y'all to ask us questions that are specific maybe to your organization and program that you haven't found answers to in our products or trainings. You can also look at the previous trainings that we have online. There's a lot of modules as well. Just a caveat on that one, they are recorded and they are sort of placed in time. And we move so fast around here and change as well. I mean, we move really fast and we also move really slow at government level, but things change really fast. So sometimes there will be a little bit of it could be a little bit of outdated information. So just understand that understanding the new rules that are out are really important. But we do try to inform HRSN service providers of upcoming changes as well. And that those office hours is a really good place for up-to-date real-time questions and answers. Thank you for the question, Arlen. I see that there are opportunities to enroll as providers. What is the timeline of this benefit being available to qualifying community members? Yeah, absolutely. The timeline is right now, this is through September 30th of 2027. So we have 2 full years of the HRSN benefit and don't see this going anywhere. Farther than that in October, et cetera, will really depend on the state's application through the 1115 waiver. We get a waiver from the federal government to provide these services. So we're doing something a little different. We need to get an exception to provide this. And we don't know what that's going to look like yet. But keep an eye out for public informational sessions. Highly recommend coming and maybe using your voice at any waiver application sessions as we build up the plan for post September 30th, 2027. Wasn't planning on saying that, but just a plug there. Okay, next slide, please. This is some bookmarked links here, just helpful information for you to take a look at. I know you can't click the links here, but I know you'll be getting these slides later, or I'm sure you will, right, Bonnie? That is it for HRSN services for now. Any other questions? All right, thank you so much. I'll put the email in the chat and feel free to reach out anytime. And I'll be here at the open Q&A at the end if you do have any questions. Thank you so much for having me today.
Thank you so much, Charissa. Thank you all. We are going to proceed to our 5-minute break. We're right on time. That was kind of our dense listening session part of it. And this next section will be really about the reporting requirements and the grant specific information I know you're all interested to hear about and to ask questions about. So we're going to take a 5-minute break. We'll be back at, gosh, what would that be? I can't do math, 2:44. Let's do that. 2:44, and I'll make an announcement a couple of minutes prior to that so you can be ready. Thank you. We're going to come back in 1 minute. Okay. Well, I hope everybody got a chance to stand up and stretch or go get more coffee or diet soda or whatever soda it is you drink or water. Um, we are going to get going with the grant portion of the session. And I know if there were a couple people that joined just recently, feel free to put your name and affiliation in the chat. And we will make sure we add you to our list of folks to receive this email after with the slide deck and the recording. I am going to move us forward, and I'm going to invite our wonderful speaker, Cassie Lemieux, to start sharing with you regarding our grant.
Thanks, Bonnie. Hi, everyone. Again, my name is Cassie Lemieux, she, her pronouns, and I am the Home and Community-Based Services Policy Manager here at the Oregon Health Authority. My team is kind of where these grant opportunities started, and I'll give you a little bit of a brief history lesson in that space. If we could move forward one slide. So about, oh gosh, probably a little less than a year ago, we had a brainchild of an idea because we had some funding from the federal government called American Rescue Plan Act funding. So those funds were provided to states during the public health emergency to enhance or increase states' ability to meet the needs of their beneficiaries through home and community-based services programs. For OHA, that is our 1915I program that you heard about from Liz earlier in this session. And at the same time, we were also beginning ramping up in offering this HRSN housing service as well. So we thought what an opportunity we had to take some of these grant funds or take some of these, sorry, they weren't grant funds at the time, these federal funds and offer them as grants to federally qualified health centers and certified community behavioral health clinics to be able to make a bridge between those two benefits, right? Knowing that when you connect housing and healthcare services for individuals, they are oftentimes able to maintain their stability in a way that they wouldn't have been able to without those services. So this was an opportunity for us to enable FQHCs and CCBHCs to provide the HRSN housing supports that Charissa did such a great job explaining about earlier to eligible fee-for-service or open card members. And again, this can include the rental assistant payments, but could also include some of those other benefits that Charissa was talking about as well. And additionally, to the HRSN housing benefit, deliver some of the core services under our 1959 HCBS program. These core services are really focused on coordinating the referral process for folks who might be eligible for 1959 services, if possible, depending on the staffing of the clinic, provide any of the diagnostic eligibility requirements for 1959 potentially eligible 1959 beneficiaries. Take part in their care planning and assist those individuals once they are determined eligible for services and getting connected to some of those services and having them start for those individuals. So the grant was an opportunity to bring those two concepts together. And we sort of looked at it as seed funding, right? So a lot of y'all might not have had the capacity or the ability to do either of those things. And we really wanted to provide an opportunity to develop workflows, staffing models, whatever that looks like for you to be able to meet those needs. See, we've got a question in the chat. That is a great question. So there is no kind of automatic provider enrollment if you enroll as either a 1959 or an HRSN provider. There are specific requirements for HRSN services or the HRSN benefit to become an enrolled provider. 1959 is a little bit easier. You really just have to be an enrolled Medicaid provider with the state to be able to provide those services. So that one's a little bit easier. There's a few more hoops to jump through for the housing benefit.
Right. So
Yeah.
if we are already a Medicaid provide, then we are HRSN. I'm in outreach, so I don't always hear about the clinical stuff. And so we have like we have a behavior health clinic and we have
Mhm.
medical and we're an FQHC, right?
Mhm.
So then we are,
Then you should be
and
good
I
to go for 1950I. Yeah. There's just
got
a
it.
few more steps for HRS, and there's a
Yeah,
couple
yeah,
forms and
and I've done
processes.
that part.
Yeah.
We're approved there. We're already approved
Wonderful.
for the HRSN provider part.
Yep.
Okay,
Then you should be good on
fantastic.
both ends.
Thank you.
Yeah, of course. All right. Let's go ahead and move to the next slide, please. All right. So one thing that is a question that we I think rightfully so keep getting asked by y'all is what are the kinds of things that we can do under this grant opportunity? What can we use these funds for? So we've got a list of these things in the next few slides, but we wanted to do a quick overview here. So the grant funding really can be used for kind of broad activities under these kind of categories. So provide the payments for rental assistance. That one is pretty self-explanatory, but this can include the temporary lodging assistance, deposit assistance, funding for utility assistance or other qualifying payments. This can also include any staff costs. So if you have increased staff costs for outreach and engagement, or any kind of screening processes, those can be included as well. Same thing, screening and identification of eligible OHP members for either the HRSN or HCBS benefits. And then any development of workflows, accounting systems, IT systems, training, and other processes, those are also included. We'll get down into a little bit more specificity here. So for HRSN grant activities, and I would invite our HRSN partners, Teresa or Tara, to jump in here if there's any questions or if I'm not explaining anything correctly, because I am not the HRSN expert in the room. But for the allowable activities under the HRSN portion of the grant, these can include any expenditures that really help clinics directly support the infrastructure needed to deliver those HRSN services. So that could be buying laptops and hotspots for outreach workers, training staff in motivational interviewing or Medicaid eligibility types of subject matter, installing secure document storage for HRSN screening forms, hosting roundtables or advisory councils, public forums, focus groups, those kinds of engagement activities, developing outreach materials, so flyers, digital media, or facility upgrades that enable HRSN service delivery. It is important to note that this is a little bit different from the 1915I or HCBS activities. The activities that I just described are not billable activities for HRSN services. So you would not be submitting a claim for those types of activities. Those are activities that you can, under this contract, use the grant funding for. So I'll pause there. That one's a little bit of a differentiation that I wanted to make sure that we made. See if there's any questions.
I think my question on this one is, when we wrote up this budget proposal a year ago, we've morphed a little bit as we begin to understand what the heck it is we're doing. Because this is totally startup money for us regarding navigators and CHWs. Totally, we're using this as startup money. So if we've been able, as we've focused and we go, maybe we want to spend this slightly differently, still under these rules, but not what we turned in and was approved almost a year ago. Are we allowed to?
That's okay.
Alter, and then we're done. This round that's okay. Okay, good.
That is okay.
Do I need to tell you first, or can I just do it as long as it stays in these parameters?
I would say as long as it stays within these parameters, you are good to go. We are always around for technical assistance, though, and if you ever need our expertise or guidance on how to operationalize some of these things, or if you just want to feel out where the guardrails are, we are
right, because I don't want to break the rules. I never want to intentionally commit fraud.
Absolutely,
that's against my daily to-do list.
That totally makes sense.
And then for those of us who this first round of this grant is up in November, and even this might be a question for later, and that's totally fine if you want to table it. What happens if we haven't spent everything because we have had began a different
Mhm.
understanding as we've moved through this. Do we get to keep it? Do we send
Yeah.
it back?
That is something that we're going to be talking about a little bit later.
Fantastic. Then let's wait for that one.
But I'll sneak preview here. We are in the process of reworking the contracts internally so that the spending period is extended through June of next year.
God bless you. You're my new favorite person.
Yeah, and I'll just kind of
hiring is so hard.
Yeah, absolutely. And I'll kind of say the quiet part out loud, y'all. When we were spending these ARPA funds, it was a rush. I know some of y'all were signing contracts the last week of March, which was the last week that we had to spend these funds.
Yeah.
So it was kind of a mad dash to get the contract signed. And then we were in the middle of legislative session here at the state. So a lot of communication, just kind of fell by the wayside, and we take responsibility for owning that as the state that issued these grants. So we are really treating this contract extension as a refresh or a reset for y'all, especially for those of you who have had difficulty in kind of this ramp up period of figuring out exactly how to spend the money or needing to pivot from your original thought processes. Because we understand that navigating this landscape is really difficult. These are two very different benefits, and trying to navigate them at the same time can be incredibly difficult. So we wanted to recognize that and offer this extension as an opportunity for y'all to really take stock of where you've been so far since signing the contracts. Come to us if you want to or need to, and you feel like you want to redesign what you're working on, and let us help you and support you through that process.
I really appreciate that you guys have already thought about that.
Yeah.
Maybe no one else is appreciative, so I just want, or we're going to say it. So
Appreciation
just want to put that out there.
So
thank you so much for those of you who worked on that already. Thank you.
Absolutely. And I see Rochelle's got her hand up too.
Oh, Eric Ashley.
I'm sorry. Yes, go ahead, Eric.
Yeah, hey, thank you. Eric Salas at Cascadia Health. I appreciate, you may get to this later. I appreciate the questions, and we were aware of the extension, which is awesome. But the question still remains, like, because we're just projecting ahead in terms of what our spend might look like between now and June. And if we get to that space in June and it's not spent down, like just for our own sort of financial planning kind of purposes, like what then? Like, is that a question you guys are able to answer now, or are you still kind of sorting that out? I know that's a bunch of months from now, but it's something that we're trying to figure out.
Yeah. I am not sure of what the technical process is, but because these were funds that were provided by the Center for Medicare and Medicaid Services, there is a requirement for these ARPA funds in particular that we return them to the federal government if they are returned to the state. They're not something that we can repurpose if they're returned to us. So our motivation there is to really work with y'all to be as creative as we can, and totally hear you, Eric, around constraints that y'all may have, and knowing that June is, several months in the future and we can't predict the future, right? But we are always willing to have conversations with y'all about what creativity can look like and where you might be seeing some challenges in the spend down, because we want to avoid having to return the funds to the federal government if possible. However, lots of states are in positions where they have to return some of these ARPA funds because we were all in the same position of spending them pretty quickly. And without a ton of guidance from the federal government. So it wouldn't be uncommon. It wouldn't be out of the question to return them, but we really want to try to work with y'all as much as we can to try to figure out how to get the spend working for you.
Thank you.
Yeah, of course. Back to Rochelle.
So just wanted to add, part of the reason we wanted to do this refresh of looking at the grants is, as Cassie stated, the flurry around how to get this out early this year. But there's also the piece about the safety net team in itself was pretty compacted, and the ability to really support how this is going to actually be operationalized. But the good news is there's a few of us new to the team that have been added. I'm one of them as the manager, but we've got some wonderful new people as well. Bliss and Vasa, who is now part of this work to really ensure that we're supporting the clinics and being able to understand, how they can leverage, because we continue to still have the North Star of not only supporting the people that are coming to the clinics and health centers for care, but also the unconventional way we can do that is supporting their living conditions or their environment so that they could get the care in a safe and stable manner.
Thanks, Rochelle. I do see we have a question in the chat. It looks pretty complicated, so I'm going to say it out loud here, and for the recording too. So Casey asked, as an agency-wide CCBF recipient, we are enrolled as an HRSN O&E, and separately we are a 1959 grant recipient on the behavioral health side as a CMHP and enrolled as an HRSN housing provider. Are there any issues with our 1959 funded tenancy housing staff to bill HRSN O&E under managed care CCO and or open card? I don't believe so. Rochelle, do you see any issue with that? I'm not seeing anything that stands out to me. Or Charissa also.
Yeah, I don't know about the HRSN piece.
I would say from the 1959 side, I think that you're good. But I would invite maybe Charissa. I don't know if we need to restate the question, but I can't answer on the HRSN, which is why we have our friend Charissa here.
Yeah, absolutely. The short answer is likely no, there's no issue. I just want to provide a little bit of a caveat. If you're receiving funds that entirely pay for the staff, the administrative, a burden, everything, and it's really specific to that staff member doing it, I think it would be considered double dipping to bill HRSN. I think it's unlikely that that's the case. I think it's most likely as you're filling out your grant reporting, which I don't know all of that, but I think it's more likely that you would be filling in gaps with HRSN services, outreach and engagement and tenancy services. That's my guess. If you want to email me directly with some specifics, or you want to, raise your hand, that's fine. But I really think that as long as you're filling in the gaps, you are saying, well, they're serving these members specifically for HRSN. The grant is helping support our entire organization. Think about that. And I would guess it would come down. I think you're with Deschutes County, Casey, and I would guess that your organization probably has some checks and balances for that. I really doubt there's any issues. Does that help?
Thank you. That helps. It does. We just had some recent guidance from our CCO under the CCBF that any position funded with that should not also be, we should not be billing for services. That position, if that position is technically funded, because that would essentially be double dipping. So that's where I'm getting a little bit wary of the funded position. And then again, if we identify an individual that qualifies, but they end up not being open card, and so they're on the managed care side, we want to be able to capture that potentially. So I just want to make sure that that's not in the gray area, but it feels like it might be.
Yeah, it's a little tough. I really would probably have to have the CCBF. I'm sorry, and I was thinking the grant recipient, which is a little bit different. The CCBF rules, I'm sorry, community capacity building funds. For those that didn't know what CCBF is, it is essentially a grant to build infrastructure for HRSN services specifically. So if it is during that time period that you're receiving CCBF and that entire position is funded and you're billing for that incremental time, then yes, that is double dipping with CCBF. So thank you for clarifying. And I missed that first little sentence there, Casey. So I think some of that is, if you want to send us some examples for us to take a look at, we would be happy to do that and help provide guidance though. A lot of it is gray here. And so I think, OHA leadership and the HRSN program, the 1115 waiver program in general, really wants to see tenancy services and outreach and engagement services utilized as well, though. So we have to walk a little bit of that line. But again, please email me if you would like specific yes, no, what do you think answers there. That would be helpful, if that would be helpful.
And just to clarify, I was just applying this other guidance, the CCBF guidance on a funded position to this concept of the 1915 I. So if that is truly, if those have different sets of rules, I really just wanted to clarify that. But yes, we can definitely follow up. Thank you so much.
Thank you.
All right, I am going to move us forward to the next slide and talk about activities under the HCBS portion of this grant. So a little bit unlike the HRSN activities that we just saw, again, because these funds are from the federal government, specifically to enhance the home and community-based services programs for the state, there are, under the 1959 or home and community-based services bucket, some specific allowable grant activities for how we can use the funds. Those are kind of across these 5 different buckets. So HCBS capacity and infrastructure, meaning if you are a facility and you need to do things like improve your HVAC or roofing, make any updates to your facility to be ADA compliant, or enhance ADA compliance, or increase any capacity within the facility. Those are approved usages of the funds. Workforce and training, so recruiting and training and retaining any HCBS facing roles. So that includes community health workers, peer support workers, care coordinators, health navigators, also very much allowable, especially if you're training staff around the person-centered service plan process, any crisis intervention or diversion. Care planning and diagnostics is part of an individual's journey through 1915 I. They do also undergo what's called a person-centered service plan once they're determined eligible by the independent and qualified agent, CoMagin Health. And the individual can bring whomever they would like into that planning process, including any health navigators, care coordinators, case managers, or other types of providers in that session to help develop that care plan. Also helping coordinate referrals and eligibility pathways, or making connections for folks to get any of those diagnostic assessments that are required. So if you see a person in your clinic who you think could potentially benefit from 1959 services, but maybe they don't have the diagnosis of a chronic mental illness or severe and persistent mental illness, and you know how to get that person connected to that assessment, that works too. Service delivery enhancements, so any type of skills training or peer services. If you want to either start or enhance any telehealth or other connectivity supports for folks in the area that you serve, that would be allowable. And any kind of clinic-based transition supports, those would also be allowable. Outreach and education is one of the big things that we would hope that clinics would use some of these funds for, because we really want to get the word about 1959 out far and wide across the state. Developing any culturally responsive or accessible HCBS materials or partnerships with other housing organizations, community-based organizations, or other networks. And also working to understand with members what their experience with the 1959 program has been like. So if you decide that you would like to survey your patients and see how the process is going for them, that is also allowable. So these are pretty broad. And again, we've met with a lot of y'all to kind of dig into some of the details around this about, well, what if we do this way? Or if we do it this way, is that okay? Again, our goal is to make sure that y'all can maximize these funds as much as possible. Likely the answer will be yes, because we want you to be creative and we want to support you in that. But you're always welcome to come to us and we call it throwing spaghetti at the wall. If that's the conversation that we're having with y'all, that's totally fine, and we are all here for it. Let's move to the next slide. So in the grant contracts, there were some required activities for both the HRSN portion and the HCBS portion. So one for both of these is to be an enrolled Medicaid provider, which we talked about a little bit earlier. For HRSN specifically, there is some enrollment processes to be an HRSN housing provider for the open card population. There is also the completion of a business associate agreement, the trading partner agreement, and receiving your first complete HRSN housing referral and request form for an OHP open card member. And then ideally, what we would love to see is a 5 HRSN housing support payments. Again, that can be rental assistance, utility assistance, but 5 of those payments going out to OHP open card members. And then for HCBS, again, you have that Medicaid provider qualification. And this one right here, number 7, is really around making sure that you are screening and when you're meeting with patients in the clinics, thinking about whether or not 1959 services would benefit them and really trying to identify folks that would benefit from those and making that referral to the IQA. Again, depending on each clinic staffing structure, if you have the ability to diagnose or verify a diagnosis of a chronic mental illness or severe and persistent mental illness, that would is another milestone. And again, if you don't have the capabilities to do the diagnostics in your facility, partnering with like your local CMHP or another provider also works there. Supporting the development of a person-centered service plan. We talked about that just a little bit. Again, that's at the discretion of the person undergoing the assessment and the eligibility. If they decline your participation, that's totally okay, but being there to offer that type of support and that type of engagement. Medical or behavioral health provider attendance at any of the virtual trainings like this one that we're holding, but we do also put on monthly webinars and biweekly office hours. So that is also something that is offered, and we welcome y'all to come to those as well. And then lastly, medical or behavioral health provider attendance at any of our virtual trainings on best practices for providing support to these individuals, especially folks who have co-occurring or complex behavioral health or developmental disabilities or physical disabilities. We do have a lot of places where we've set up partnership with the Office of Aging and People with Disabilities and the Office of Developmental Disability Services, and recognize that y'all probably see folks in your clinics that have complex and co-occurring disorders, and we want to make sure that you know that there are spaces that we've really tried to cultivate where we've got subject matter experts in the room who can help connect those folks to the people and the places who can make sure they're getting the services that they need. Well, that's a good question in the chat. So Arlen asked, on average, how long does a patient stay on open card? Asking because if it is less than the 6 months, how could we provide 5 consecutive payments? That doesn't necessarily mean 5 consecutive payments for one individual, just 5 total payments for the entirety of the spending period. And the time period for how long someone stays open card really depends. Typically, the way that it is occurring right now is everyone is basically fee for service once they are approved for OHP. Most people move into a CCO. However, there are some folks who either choose to or remain fee for service. For example, anyone who is American Indian or Alaska Native is required to choose whether or not they want to be fee for service or open card, because we are not able to auto enroll them in CCO services as part of the federal government to government relationship with the 9 federally recognized tribes of Oregon. But there's also some folks who benefit more from having fee for service than open card. So just it kind of depends. Let's go ahead and move to the next slide. All right. Talking a little bit about reporting, which is another question that we get a lot. So we do have a template, and we will share that again with y'all once we send these presentation materials out. There are about 4 sections of reporting requirements for this particular grant opportunity that we do require on a quarterly basis. And again, we'll go into how this correlates with the grant contract extension too. But overall, on the reporting, we do need you to provide your clinic information, so your name, the reporting period, and the HRSN covered population that you're serving. Provider enrollment, so making sure that you are an enrolled provider. Typically, if you've done that once, it'll just stay the same on each of the templates, so you don't have to repeat that information. Service provision, so reporting of any of the services that you have delivered, any quantitative data in regards to those services and referrals that you've made. And expenditures, so providing a comprehensive list of expenditures related to either the HRSN or HCBS portions of the grant. So say you spent, 20% of it on a position for a health navigator. That would be something that you would want to describe in terms of the expenditures. And next slide. Oh, perfect. Thank you, Bonnie. So these are some additional required activities that all of our grantees must complete. So all of the grantees at contract execution should have obtained insurance that is specific to Exhibit B, Section 10, and Exhibit C before you deliver any of the services that are part of the contract agreement. This one we have here, these OHA monthly meetings, again, we are treating this as a refresh. Realize that we have not had a lot of monthly meetings for y'all to attend since you signed the grant contract, so we are reworking that as well. But a lot of y'all do a really good job at reaching out to us when you do have questions or do want to meet. So we will be reworking this and reaching out and letting y'all know what this is going to look like moving forward. But this will continue throughout the duration of the contract. It might just look a little bit different than what's been described so far. We talked a little bit about the quarterly reporting, and then also we are requiring a final report. So what we would love in that final report to see is all of the kind of required quarterly reporting and accounts for all of the expenses for the funds that are dispersed. And I would also say any qualitative information y'all have to share as a result of participating in this grant opportunity. This is the first time we've really done anything like this on the HCBS side of the house. So any kind of qualitative information that that y'all feel comfortable sharing with us would be really, we'd be really grateful to read that as well. So we could learn and when we get opportunities to do things like this in the future, we have something to work from, right? Ways that we can do better and improve on processes. All right. So here you're seeing our reporting requirement states. One of the snafus that we should probably mention is that once when we were going through these grant contracts and getting folks to sign them, we had a wonderful person on our team named Mariah Andrews who was working really diligently with all of you to make sure that your questions were getting answered, that we got all the right signatures that we needed, and then everything was going through the right process. Then Mariah went on maternity leave because she decided to have a baby, which is wonderful. What happened in that process is some of the contact information didn't get changed over. So some of y'all might have sent some of these reporting requirements to Mariah while she was on maternity leave, which is okay. She is back now and probably going through many, many emails and finding some of these things from you as well. But that's okay. What I want to emphasize here is that for clinics who have provided reporting, thank you, whether or not it went into Mariah's inbox or not. For those who have not, maybe because you don't have anything to report, right? Maybe you are one of the clinics who have struggled kind of in this ramp up period. That is also okay. As a result of us extending these grant contracts, you are not going to be penalized or at risk of violating any of the contract requirements because you did not provide reporting up until this point. With the contract extensions, required reporting will be enforced for the period that covers October 1st through December 31st, which means that there will be a required quarterly report on January 30th, 2026. If desired, you can include any additional reporting activities prior to that October 1st, 2025 date. And you can also include that in the final report as well. So I want to pause there on the reporting questions because I know that might be a little bit confusing. Maybe I said all the right things and it's not confusing. Yay. Okay. Let's go to the next slide. So we've got some instructions here for the reporting process. So again, there is an Excel template. We will make sure to send that out to y'all again. You'll want to complete the fields that are required within the reporting template, which are marked in that template. Save and label the file with the appropriate naming convention, which we have out here for you. So what quarter you're reporting for, what year, the name of the clinic, and then the title, Safety Net Clinic Report. These are all going to go to Vasa and Bliss, who are team members of Rochelle's, who she mentioned earlier. And then if you could please CC our 1959 Medicaid policy inbox, noting that at some point Vasa and Bliss might want to take vacation or might be out sick. We want to make sure that there is kind of a catch-all inbox that's catching these as well. But the folks who are going to be responsible for collecting and kind of organizing these quarterly reports are going to be Vasa and Bliss. And next slide.
Cassie, I do want to do a time check. We have got about 10 minutes left, so I'm going to move us to that template.
Sounds good.
Let me know when you want.
Go for it.
Can you see that?
Yes.
Okay, good.
All right. So you'll see first here on the screen that Bonnie is sharing some instructions which have the reporting timeline, and you'll see that we've got it extended here as well for the grant contract extensions. You've got some contacts here as well for who to go to if you have contract questions, if you have enrollment questions for HRSN, billing questions, or HCBS support questions as well. And then if we go to the actual reporting template, you'll see that these are the sections where we ask y'all to put in some of that specific information. So your provider enrollment, your HRSN housing referral information, anything related to the milestones that we talked about a little bit earlier. These are free text response boxes. So if you feel like if there are numbers you want to put in, but if there's also some, again, qualitative information you want to put in there, please feel free to do so. Bonnie, can we scroll down just a little bit? Yeah, so you'll see spaces for referrals, person-centered service planning, if we're talking about the HCBS portion of the grant opportunity. And then we've also got a section for expenditures. But again, if you have any questions on the reporting template, if you're like, gosh, I'm really not sure if I'm filling this out correctly, we are happy to meet with you to go through the template. We want to ease any anxieties that y'all have. And also if you submit it and we're like, hey, we don't really understand that, we might reach out to you just to make sure that we are 100% understanding what you're meaning to report and we get that reflected correctly. And then I think we can go back to slides, Bonnie. All right. So as Bonnie mentioned, we have lots of contacts for y'all to get a hold of if you have any questions. For grant technical assistance, that's going to be our HCBS policy team because we are where the grants originated from. So that's that 1959 Medicaid policy inbox. Again, reporting submissions are going to go to Vasa and Bliss with that 1915I email box CC'd. Any enrollment TPA or BAA questions for HRSN will go to this email here, the orhrsn@acentra.com. We do have a specific email address for billing, which will go to our partners at IAN. We have both a website and a phone number here and the times that they're available. Our Safety Net Clinic team, if you have any questions for them, Rochelle very kindly put her own email address right here for you. And I can vouch she is very lovely to talk to, so please reach out to her as much as you want. Our HRSN policy team, again, Charissa and Tara and the other members of their team can be reached here. And then we also have an email address for our partners at CoMagin Health if you have any questions regarding the referral, eligibility, or person-centered service planning process. So that's that orbhsupport@comagin.org. And we don't have a ton of time left for Q&A, but we did a really good job answering questions throughout the whole session. So I will pause here and see if there's anything that's coming up for folks right now.
And feel free to share, anything that you guys have been working on, or any milestones that you guys want to share with the group of where you've decided to go with that too. Any of those would be welcome.
And if you can't think of anything right now, that contact card that we just showed on the last couple of slides, that's a good place to send your questions. If you're, cooking dinner at 6 o'clock at night and you're like, oh man, I really should have asked this during the webinar. Those are the places where you can send it. And we're happy to again, have any kind of conversations or meetings with y'all to help work through this process.
Definitely. I will be launching a poll in a couple of minutes of just an experience survey for this session to help us get better as we go along providing technical assistance. So, but still feel free to raise your hand or come off mute.
Hi there, this is Casey Burgess with Deschutes County Health Services. Thank you for this very informative session today. I think that my earlier question, everything sort of came together for me. And this is really, I think the important takeaway is really that this is while there's a lot of overlap with HRSN, this is a separate funding stream because of the ARPA. So ARPA is the funding behind the 1915I, and okay, so the Medicaid 1115 waiver is to CCBF as ARPA is to 1959. Is that accurate?
Yes, that is
okay.
We should put that in these slides.
Okay,
that is
thank
a
you.
really great way to describe it, actually.
That's so helpful, and it just really makes things cleaner for me to just kind of think about how we're structuring the way that we're providing and billing for services. Thank you so much.
Yeah, and thanks for the idea. We were probably going to take that and put that in these slides.
Thanks.
We got about 4 more minutes. We welcome any other thoughts or any challenges or questions that you might have as well. And that poll should be up on your screen as well. As a reminder, we are going to provide the slide deck and the recording. It does take me a couple of days to get the recording put into a YouTube video and link. So we'll be emailing that out as soon as we have that available. And then you'll have all of these resources at your hand.
Thank you so much. This has been really helpful.
Thank you all as well. I will move us forward. Oh, did I hear a voice?
No, that was just me.
Okay, I was going to say, I'll pause. Well, I'll move us forward to closing out. We appreciate all of you for spending the time with us today to learn a little bit more about it. And again, we really want to encourage outreach. Like Cassie said, we are available for technical assistance one-on-one. Each of the clinics have chosen a different pathway of how to utilize these funds. So it's definitely appropriate to have one-on-one conversations. And that's what we're here to support. So whether it's the HRSN or HCBS teams or both of us at the same time, we can definitely coordinate conversations. So just go ahead and reach out and we will get those things set up. And we look forward to seeing all the creative ways that these funds will be used to expand access to HCBS and HRSN services. So we really appreciate you all. Thank you all to my presenters, and we hope to be corresponding soon about new outreach on that monthly basis that we talked about for OHA monthly meetings, and we'll be sending out some correspondence about that as well. So we thank you so much, and we hope you all have a good rest of the day.